Good morning, one and all. Thank you so much for attending this morning. Welcome to this webinar today on menopause, well, working through menopause, apologies. And I am delighted to be joined by a distinguished panel of speakers who are going to be going through today. But just to introduce myself, my name is Nick Caton. I am the chair of the Alliance for Finance. Some of you will know me, some of you are meeting for the first time, so welcome. And as I said, I'm delighted we've got a great panel today of speakers talking about menopause in the workplace, as well as, well, from all angles, really. We will hear from HR specialist Jo Williams. Welcome, Jo, from Zurich Insurance. Clare-Louise Knox, business psychologist and founder of SeeHerThrive. Carolyn Harris, MP for Swansea East and deputy leader of the Welsh Labour Party, will also be joining us. Carolyn has been held up in a ministerial meeting, but she will be here shortly. And first of all, Dr. Shabari Hosur from Weston House in Gloucestershire. So in a second, I'll pass over to Dr. Hosur to start us off. Just a couple of bits of housekeeping, really. Now, we have the chat function, and we encourage everyone to share your own questions and experiences in the chat function. If you have any questions specifically for the panelists, then please add them in as well. And Carolyn Taylor, my colleague, will be doing her best to monitor the chat and raise those with the speakers as we go through. If you're having any technical difficulties, I'm not a complete IT expert. We've done this a few times, and basically, if you are having major difficulties, you can email me at info@alliance4finance.org, and I'll probably tell you something incredibly insightful, like, have you tried turning it on and off again? So just email me with any of those questions if you need to, and I'll try my best to have a look at that. But without further ado, we've got quite a lot to get through today, so I will pass over straight away to Dr. Hosur to start us off. So thank you very much.
Thank you, Nick. So good morning, everyone. And I'm just going to try and share my screen first, whether my presentation comes up. Can everyone see that? And I think I need to probably go to my first slide rather than the last slide. So please bear with me. How about that? It says working through menopause. Can everyone see it? No, okay.
Can't see it yet.
Can't see it yet. How about that?
Yes, there you go.
It's okay? Good. Okay. So good morning, everyone. I'm Dr. Shabari Hosur. I'm a GP partner in Weston House Practice in Cheltenham from southwest of England. And thank you for inviting me to give this talk on working through menopause today. Just a bit of background, menopause is a very big topic, and I've been allocated only 20 minutes. So I think I'll be just touching the tip of the iceberg. Like it says in this leaflet, which was passed around or shared with everyone, women over 50 are the largest growing demographic in the workplace, and with the average age of menopause being 51 years, 8 out of 10 women are going through menopause in employment. So it is clear that this is an important topic for all the workers, employers, and trade unions. So every woman will go through the menopause. And it's a physiological process. You cannot bypass it. But for each, the experience will be different. The menopause symptoms doesn't begin at a particular age or last a definite or a fixed period of time. And the symptoms can vary from woman to woman. For many women, the menopause occurs as we age and the ovaries naturally fail and they stop producing the estrogen and the progesterone. But for some women, it could be because of specific therapy like chemotherapy, radiotherapy, or when the ovaries are removed surgically. So just to reinforce that information, the symptoms we have is because of the hormones estrogen and progesterone, lack of estrogen and progesterone. Now that's a diagram of a female reproductive system. We have got the womb, the fallopian tubes, the ovaries, the cervix and the vagina. The reason I wanted to share an interesting fact, and that's the reason this is here. Now, these two ovaries which are here, when we are born, we have got 1.5 million oocytes. Now, these are all capable of producing the estrogen and the progesterone. When we achieve menarche, that is the day when we start our periods, it seems 1/3 are lost during that time. And rest of your life, you keep on losing more and more. At menopause, there won't be any more oocytes, so you won't be producing estrogen and progesterone. So coming to the definition of menopause, menopause. So it basically means when menstruation stops permanently due to the ovarian activity stopping or the ovaries stop producing eggs. Now, for example, if a woman has a last period, clinically, if the woman has not had periods for 12 months, we look back and say they have achieved menopause. Now, during this time, not only menopause, there are certain terminologies which you need to know what they mean. So the first one is perimenopause. Now, this is the period before the menopause, and it is characterized by irregular cycles of ovulation and menstruation, and it ends 12 months after your last period. For some women, it might be few years or few months. For some women, it might be a decade. What do you mean by postmenopause? Now, this is the time after a woman has a last period, 12 months have gone, clinically you call them, they've achieved menopause, time after that is called postmenopause. When do you call a woman has achieved early menopause? Now, if the ovaries stop producing the hormones between the age of 40 and 45, then it is early menopause. Now, premature ovarian insufficiency, I know it's getting a bit technical, but it will definitely help to have this background knowledge so that it will help the employers to support the employees when they're going through these symptoms. Now, coming to the premature ovarian insufficiency, it is when there is a transient or a permanent loss of ovarian function before the age of 40. So can you imagine? That's, 40 is quite young age, even in terms of the work life of any person. Coming to the facts and figures. Now, from the leaflet, we know that the mean age of natural menopause is 51 years, but it can range from, a lot of years, depending on whether it is early menopause, premature, ovarian insufficiency. However, it can happen between 45 to 55 years, and unfortunately, women can experience these menopausal symptoms all that time. 1 in 100 women can be less than 40 years of age when they reach menopause. 1 in 1,000 women will be less than 30 years of age when they reach menopause. Now, that's a big deal because it's about their fertility, it's about the symptoms they have to manage, and the number of years that they have got ahead of us in terms of professional and personal life. Coming to the symptoms and effects. So these are put under these categories. The first one is menstrual irregularities, vasomotor symptoms. So these are the important ones, which is immediate or short term, which means as soon as the ovaries stop producing the hormones or the ovarian function is tailing off, you can get these vasomotor symptoms. These are hot flushes, night sweats, palpitations with it. These are the ones which has got a major effect on the quality of life of the women, their sleep, and hence the ability to come to work and give their 100%. Now, all of this obviously will have a psychological effects. Now, these are probably the immediate or the short term. Now, coming to the medium term effect, they can have what we call it as genitourinary syndrome of menopause. What it means, basically, the lining of the vagina, the urethra, and the bladder are very dependent on the female hormone estrogen. And when we don't have the hormones, they thin down, they become dry, and they are more prone for infections. So they get recurrent urinary tract infection, they get dryness, there might be pain, etc. Now, the most important effects of the menopause is cardiovascular disease. What do you mean by cardiovascular disease? It's, of course, long-term effect. basically the risk of women having heart attacks. So when a patient comes to me with perimenopausal or menopausal symptoms, I do a complete cardiovascular risk assessment for that woman. We would look at their weight, whether they smoke, whether they drink. They do their blood sugars to see whether they are pre-diabetic or diabetic, check their blood pressures and their cholesterol levels, give an overall cardiovascular assessment, because the estrogen has got a protective effect. The minute you lose that hormone, your risk is equal to a man. The last one, but not the least, is osteoporosis. That is the thinning of the bones. These are long-term effects of menopause. The next few slides I have got for the symptoms, because that's what people should be aware of, because you're going through all of this mentally and physically, but if you don't relate those two things, it's difficult, isn't it? So the first symptom is usually a change in the monthly period with light or heavy periods and irregularity in their occurrence. Normally what should happen is there are far and few, it should be light and it should stop. However, again, every woman experiences different symptoms. The other symptoms can be physical, psychological, and sexual problems. So I'll take a nice deep breath and go through all of them. Then you know it. Why do we get all these symptoms? And the reason being, we have estrogen receptors from the brain till the toe, right? Hot flushes, night sweats, insomnia, palpitations, that is having, fast heartbeat, headaches, aching joints and muscles and tendons, irritability, mood swings. Oh, doctor, I had 2-3 patients yesterday, and they said, 1 minute I'm happy, 1 minute I'm sad. I don't know what's happening. I feel I'm having a nervous breakdown. Anxiety, panic attacks. One told me, I woke up with a knot in my tummy, but today is my day off. I don't know why. Poor concentration, poor memory. They say, I've got a brain fog, loss of sex drive, discomfort during intercourse. All of this obviously has got an impact on their professional and personal lives. Now, again, as I said, the hot flush is something that we hear a lot. And, that is something that people and also the employers should be aware of. And because that's where you can probably bring about some changes to help them. What is a hot flush? Now, hot flushes can occur before your period stops. As I said, when the ovarian function tails off, you can start having them. Normally, it should stop after 2 years after you have your last period. Unfortunately, in 10% of them, it can continue up to 15 years. What is a hot flush? It's an uncomfortable feeling, and you feel subjectively the way women explain to me is, doctor, I feel something is coming from bottom to top or the other way. It starts with the neck or the chest and either goes down or goes to the face. And they feel there is that feeling of heat. And then this can be associated with nausea, sweating, profuse sweating sometimes, followed by a chill and palpitations. It can be quite troublesome at night, and that interferes with sleep. Again, for employers, it is very important to understand if they're going through that, they may not be sleeping as much, they may not be 100% during their work hours. It affects 85% of the women. About 20% of them, as I said, they might experience it when they're still having periods. It's in some women, it can be every half an hour. It can occur 8 to 15 times in a day. That can be very intrusive, very troublesome symptom. And it lasts about 4 to 5 minutes. I've talked about the genitourinary syndrome, so I'll go to the next point. People can have dry skin. Yesterday a lady was telling me, I cannot wear my contact lenses, doctor. It really irritates my eye. And hair fall. The next one is more for I'll leave that slide there because you can circulate my slides later on. And this is more for information where you can see, there are lots of symptoms which we may not think it could be because of a hormone or lack of hormones. How do you diagnose it then? So for clinicians, it is a clinical diagnosis. So if a woman comes with perimenopause or menopause symptoms, and there is a change in the menstrual pattern, which is associated with the symptoms which I've just explained, then anyone above 45, it's a clinical diagnosis. I don't need any test to confirm the diagnosis. What does NICE say? That is the National Institute for Health and Care Excellence. What does it say? There is a hormone called follicle stimulating hormone blood test. But this cannot be used, or there is no need to use if you're over 45, and anything below that you can use it. Why does it give a diagnosis? Now, a little bit of science behind it. Again, ovaries produce estrogen, which is the female hormone, and also the progesterone. They give a negative feedback to the brain or the pituitary, and which produces follicle stimulating hormone. When the ovaries are not producing the estrogen, the negative feedback is lost, so the FSH is more in your blood. Now, when you do a blood test, anything more than 30, twice, that is 4 to 6 weeks apart, will give a diagnosis, especially in women who are younger. So treatment, can you do anything? My God, I have, seen all these symptoms. We have diagnosed it. Is there anything we can do about it? Of course, there is treatment. And a lot of it, a lot of the symptoms can be treated optimally with various combinations of HRT. Now, despite the controversies surrounding the risk and benefits, hormone replacement therapy is the mainstay of treatment in this condition, because you are having the symptoms because of the lack of estrogen and progesterone. So obviously, you have to supplement it. Now, the HRT uses more natural steroids and in lower doses, not in big doses like the contraceptive pill. Lifestyle measures, for example, the same things that you do for all the chronic diseases, for all the well-being stuff that you do, good diet, healthy lifestyle, quit smoking, and have alcohol within the safe limits. Lifestyle measures in terms of wearing a clothing that is appropriate for you, and then create an environment within the office which you can work when you're getting all these hot flushes. Psychological support, in terms of, because for women who have never had any mental health symptoms, suddenly they think, why am I so emotional? Why do I feel low one day? Why do I feel happy myself one day? So the psychological support will help. Unfortunately, sometimes for women who already have got mental health, it can get a little worse. So the psychological support really helps. Diet and supplements. So because we talked about osteoporosis, which is the thinning of the bone in postmenopausal women, which leads to thin bones and more risk of fractures. Example, hip fractures, fractures of the vertebra, low trauma fractures. For example, women will say, I was walking the dog and he just pulled, I fell on my wrist and I've broken it. I can't believe it wasn't a big impact. And sometimes you pick up that way, that they've got thin bones. And why? Especially in someone who is young and you're not thinking menopause is a reason for all the symptoms that they are having. For women who cannot take HRT, there are pharmacological alternatives. And these are the medications, gabapentin, pregabalin, SSRIs, which are mainly used as an antidepressant, but it can be used for vasomotor symptoms as well, that is hot flushes and night sweats. They help less than HRT, but of course, some women who have got, say, breast cancer, they cannot have the HRT, so there are alternatives. There's tibolone, another tablet. Now, stellate ganglion blockade, that's getting too technical and medical here, but basically what it is, it's an operation a woman can have when you have tried all the HRT, but still they have got malignant, sort of really, every hour they are having, or every half an hour they're having these hot flushes and they can't cope. I have to be honest, in the last 21, 22 years that I've been a doctor, I have never heard anyone needing a stellate ganglion blockade. And of course, the complementary therapies in terms of yoga, meditation, Tai Chi, all of those things does help. So just a little bit of about the treatment. Two common things or simple things that you need to remember is you need estrogen, you need progesterone. Estrogen is the one, lack of it is the one which causes a lot of these symptoms. You cannot give only estrogen for women who have got a womb, because the estrogen will make the lining of the womb thick, which is a precursor for endometrial cancer. So if someone has got a womb, they need a combined HRT. If they don't have a womb, have had a hysterectomy for whatever reason, you can give just estrogen. Some women may not have all of these systemic symptoms. They might have just local symptoms of the vagina and of recurrent urinary tract infections. You can just treat them with locally delivered low-dose estrogens. This is a nice sort of algorithm which tells us, what are the things or what are the different combinations of HRT a woman can have. Just to remember, women can start having the menopause symptoms before they stop period and after they stop period. If it is before they stop period, you have to mimic the way their cycle is. So you get a cyclical combined therapy. Now, if it is post-menopausal, then you get a continuous combined, because now you're not menstruating, you don't need a period, so you get a continuous combined HRT. The estrogen can be, you can take it orally, you can put it as a patch, you can have it as a gel. Progesterone, you can take it orally, or you can have a coil called Mirena coil, which helps both with contraception and also protecting the womb. The next slide, goes into treatment a lot. Yes, again, because psychological effect is quite important. Again, that has got a bearing on their professional and personal lives. So it is important that you proactively ask about it and help them and support women. Now, if they just have vaginal symptoms, you can treat just locally with a tablet, an estrogen ring, or a cream, or a pessary, and 80 to 100% of them will have a good response from it. And you don't need to protect the womb, because when you give the estrogen only to the area where there is a problem, the absorption is not that much that it will cause any problems with the uterus. And there are non-hormonal vaginal moisturizers, because for women, again, some of them, they react quite badly to the hormones. There are non-hormonal preparations. About the HRT, you are supposed to have a regular review. And the NICE says that you should look at, should you reduce the amount of HRT you're giving, the dose of it, and should you continue or should you stop now? And I will tell you why when I come to complications of HRT. One thing which I want to get across to everyone who is listening is the replacement of the estrogen after the menopause has not been shown to be effective in preventing heart attacks. The HRT, mainly all other symptoms which I was talking about, which is immediate and medium-term symptoms of menopause, it will help, but not cardiovascular disease. So complications of menopause. So if woman is naturally has achieved menopause and it is post-menopausal period, as I explained, they are more prone for thin bones and they can develop osteoporosis, which results in bone fractures. So it's really important to have a really good diet, which has got calcium, vitamin D, and you need to do regular exercises, including weight-bearing exercises and resistant exercises. In women with early menopause or premature ovarian insufficiency, all causes of mortality is higher. Cardiovascular disease, type 2 diabetes, depression, again, osteoporosis and fractures. Now, it's not all doom and gloom rather. So, there are treatments, it is treatable. What about pregnancy? Now, a lot of women I have heard, oh, doctor, my periods are irregular. I'm started having all these hot flushes. I don't think I need contraception. You do, especially if you don't want to plan a pregnancy. You've completed your family. If you're in a relationship, it is important that you follow contraception. So the pregnancy rate in those who don't use contraception is 10 to 20 per 100 woman years if you're 45 years of age, and 5 per 100 woman years if you're 50 years of age. So what are the different types of contraception a perimenopausal woman or a woman needs to follow? Now, it could be almost the same choices you have as anyone during their fertile period. You can have a combined pill, which is up to 50 years of age. You can have a mini pill if you're someone who are very religious with taking medications. Obviously, you shouldn't miss it, etc. You can have an implant. You can have a coil. You can have the progesterone coil, or you can have the copper coil. I would be quite careful and make that informed decision with your clinician if it is an injection, because the injections are known to cause more of osteoporosis. And of course, the barrier contraception and natural methods. Word of caution. I explained to you what is postmenopause. So if a lady has a last period and then 12 months have gone, clinically they're, postmenopausal. If you have a vaginal bleeding, never ignore it. Please go to your GP, because it is an ominous sign, or what we call it is a red flag in GP language, and up to 10% of these cases can be endometrial cancer. Of course, the HRT can be associated with increased risk of breast cancer. These are all the useful contacts. As I said, probably I have just touched the tip of the iceberg. However, I'll just open it out for Q&A so that we can have a discussion rather than me just talking. There are lots of useful contacts, useful websites, and out of which one of them which just stands out for me is, the DAISY network. This is the one for women who achieve menopause less than 30 years of age. British Menopause Society, they have fantastic resource. I use it a lot, lots of clinicians. It is for people and also for clinicians. My take-home message to all of you is, menopause is a physiological process. You cannot bypass it. Every woman will go through the menopause, and for each the experience is different. Symptoms vary. Do not go through it alone. Be open, seek help from family, friends, professionals, and employers. And employers, please, do the ones which you're doing, the sessions like this, to increase awareness, have more knowledge, so that it empowers you to support your employees when they come with these problems. Any questions? Thank you.
Thank you so much. I can see that there have been some questions come through. I'll pass over to Caroline in a second. I know there's quite a lot of information there. I did see a couple of people ask for the slides, and I'll just confirm, yes, we will share those afterwards. And I'd also like to welcome Carolyn, who has joined us recently, and we'll pass over to Carolyn in a second. But first of all, Caroline, is there any questions from the attendees?
Yes, we've got a couple, some great questions in there. So I'll run through, there's four main ones, and then let Shabari answer them. But first one was, if you're on the contraceptive pill, which stops your period, how would you know if you haven't had one for over a year? And would you get other symptoms with the menopause if you're on the pill?
Yes, so closer to the time, normally you will be on a mini pill. So, and you may not have a period on them. How do you know that you have reached menopause? By you will start having the menopausal symptoms. You will have hot flushes, night sweats, you're more emotional, can't sleep, you've got achy joints, there might be a bit of headache. So these are the symptoms which is going to tell you it is possible that your ovarian function is tailing off. And in these women who don't have a periods, we can still do the blood test. Not always necessary, and then see, because they might be thinking, I'm still in a relationship, I need my contraception, I definitely don't want to be pregnant, the 5 out of the 100. So what we do is we do the FSH. I had an exactly same patient yesterday who was 53, was getting all these symptoms. She was on a progesterone only pill. How do I know I am menopausal? Do the blood test. It was, her FSH was 113, and we started HRT, and I think I've got to follow up in 4 weeks' time to see how she's getting on.
Someone has just said not everyone has symptoms though, do they? So they can go through it without having any of those symptoms.
Maybe mild, and just with, just lifestyle measures and this, they may not need a treatment. So yes, there is a percentage of women who may not have. I think in one of my slides, I have said 85% of them will have hot flush. So there might be around 15 to 20% who just naturally, go through the menopause.
Thank you. Next question was, do you have to have irregular periods to get a menopause diagnosis? Could it just be light or intermittent changes to periods?
So the periods wise, it's a clinical diagnosis. As I said, you need to have the last period. It has to be 12 months. And then you say that you have achieved menopause. However, again, you have to individualize the care depending on all other comorbidities, how the woman is. You need to see if the periods are very close together, very heavy, or very far away. You need to keep in mind about, the worst thing what can happen. So we keep an eye for endometrial cancer. If not, it's 12 months. It's 12 months.
Thank you. Just two more. Are there any recommended supplements that you think would be good for people? So aside from the medical side of it, any extra supplements that you would recommend?
I think, evening primrose oil is something that they have said. As I said, the calcium and vitamin D is really good. And general multivitamin is also good. But if you go to British Menopause Society website, there is a lot more information on that. But mainly for bones, I would say good diet with supplements of calcium and vitamin D. And, overall symptoms is a multivitamin and a evening primrose oil capsules.
And another one that's come in is, does having dense breast tissue prevent you from using HRT?
No. Yes, in terms of like just not having dense breast tissue, but if you've had a personal history, family history of breast cancer, then you have to be, and again, I have a slide with all the numbers, which I didn't want to bombard you with, but for 1 year, you can the risk for any woman, even with the family history of breast cancer, using HRT is still safe. Any more than 1 year, then you have to be you have to make that informed decision with your clinician.
Thank you.
Thank you all.
Great, thank you very much. Shabari.
Any more, Caroline, or I'm done? I'm off the hook, am I? Or
there was one last one that's literally just come through.
That's okay.
If on a Mirena coil and on HRT, if having intermittent breakthrough bleeding, should you speak to your doctor? So if you're on both the coil and having HRT and you're still getting intermittent bleeding.
So the Mirena coil is the progesterone part of the combined HRT, and then it's possible that they're having estrogen in either orally or like a gel. If you have intermittent bleeding, I would, depending on the age of the patient, I would still speak to your GP. Yes, I would. Because what they can do is they can organize a scan, look at the lining, what is the thickness of the lining of your womb.
That's great. Thank you so much, Shabari. That was really informative. There's a lot of information there. And as I said, yes, everyone, I will share those slides. So that's really helpful. Thank you so much for that.
Thank you for having me.
Not a problem. Not a problem. Right. So as I said, we are joined by Carolyn Harris as well. Shabby, are you able to stop sharing your screen, please? And I'll spotlight Carolyn. And I will just pass over to you, Carolyn. You are on mute. Great. Carolyn, you're on mute.
Hello.
Hello, there you go.
Lovely to see you all. I'm probably going to say a lot of things that Dr. Shabira is not going to agree with. And one of them I'm going to read to you. And this is from the Obstetrics and Gynecological Journal 2022. And it says, why synthetic progestins are the risk in HRT, synthetic, and why we should use a body identical progesterone, like utrogestin instead. A study of UK women showed no risk of breast cancer with estrogen-only HRT and no risk for body identical progesterone. Part of the problem we have at the moment in this country is the lack of knowledge with the medical profession and women and society in general around what the menopause is and how we need to deal with it. The old style HRT, the old stuff, there may have been a risk of breast cancer. I'm not an expert, I don't know. But the body identical stuff, which is available now, and which is what you should be asking your doctor for, is made from yams. and you will not get breast cancer from that. In fact, I've seen a study that says you're more likely to get breast cancer from red wine than you are from body identical HRT. When I get emails and phone calls and letters from women who are so desperate to get their life back together, it is heartbreaking. Women who phone me and say they have begged their doctor to give them HRT, for their doctor to say, according to the blood test, you're not hormonal. And yet we know that the blood tests are not reliable. Nobody knows a woman's body like the woman. There are over 30 symptoms of the menopause. Over 30 symptoms, which a vast majority of doctors don't recognise as being the menopause. Women are being sent for tests for early onset dementia. Women are being told that potentially the brain fog could be something else. Women are being diagnosed, like I was, with antidepressants. 12 years I was on antidepressants, believing myself to be depressive, to discover in 2018, 8 years after, that I was actually menopausal, because I'd not given my doctor all the symptoms, and that was my fault. But in the case of so many other women, the doctors are not recognising and making the link between the woman's symptoms and it being menopause. And what does that mean for women? It means that women are losing a fantastic opportunity to get on with their lives and live their lives in a normal way. My life has been completely transformed since I started on HRT, and I didn't go on it until I was 60. I went on it last year, and I have seen a phenomenal difference in how myself I feel. I'm on the three HRT. I'm on estrogen, progesterone. I'm also on testosterone, but I had to go private to get it. Women who are on low incomes are the losers in this, because they are not able to afford a private diagnosis which allows them to have HRT and to get their life back, which is, it literally is that different. You feel that different. We are losing women. Women are losing relationships. Relationships are breaking up. The increase of domestic violence for women who are menopausal increases. There's a 16% rise in suicides of women who are menopausal because they can't get a diagnosis. Women are walking away from jobs or reducing hours. Women are making bad decisions, and I'm even going to suggest some women get involved in the criminal justice system because of those bad decisions, because they are turning to an alternative to take their mind off just how bloody awful they're feeling. And I've met quite a lot of women who have become obsessive about alcohol, drugs, and in some cases gambling, and end up in a situation where they commit a crime in order to fund those addictions. I've met so many women who have lost huge chunks of their life. And I think back to the old days and how many women were actually consigned to a mental asylum because some doctor decided that they were insane, when in fact they were menopausal. Because this haven't arrived on the earth in the last 2 years. This has been with us from the beginning of time, and it will be with us till the end of time. We have got to stop the myth around HRT being dangerous. We've got to get doctors, nurses, community pharmacists, GP pharmacists trained up in the ability to recognise and to prescribe the correct treatment. Now, there are some women who can't take HRT, and there are some women who do not want to take HRT. But I would never recommend you take an alternative supplement as an alternative to HRT if you are able to take HRT. There is quite a progressive movement at the moment. We've seen since we started talking about it in Parliament, and since grassroots campaigners and some celebrities have started talking about this. And one of the biggest problems we get is the myth busting. It's actually convincing GPs and convincing society that this is all these things that they were told about HRT being dangerous, and all this misunderstanding about what the menopause is and how much of a hindrance it is on a woman's life and a woman's ability to thrive in society and to thrive in our marriage and to thrive in the workplace. It keeps women down. It stops women doing anything and everything they should do. I actually did a politics live show on Monday where a woman had written an article about menopause, and she said that we were men-splaining and that we should not be discussing menopause with men because it would stop men from giving us jobs because they would think we were incapable of being a productive member of anybody's team. As long as we have anyone, especially women, thinking that, we as society will not move on, and we will not give women every opportunity to thrive and be wonderful in this world. And anyone who tries to hold them back, then I will have very harsh words for. Because no woman should have to go through what millions of women are going through. We're 51% of the population. We've been kept down long enough. Employers, doctors, corporates, politicians, women, men, children, everyone should be talking about menopause as a mainstream conversation. They should be making the correct decisions with all the information. If you haven't got the information, don't talk about it and go and find the information, because every negative comment about what we should or shouldn't do for the menopause only does a bad service to women. So I'm a bit of a pilgrim on this, and that I get really upset when I hear people saying, you know, that doctors always make the right decisions, because they don't. Doctors don't always make the right decisions. Too many women have taken their life because they've not been able to get the correct diagnosis and the correct medication. And that disappoints me greatly. We have to change that. Now, menopause is not on the curriculum for 41% of medical schools. And for the 49% who actually do have it on there, it's anything between 15 minutes and 2 hours. I'm not demonising GPs. They've not been given the resources to understand this. There's over 31 symptoms. GPs are busy. It's easier for them to write a prescription from an antidepressant than it is to sit down and have a conversation about menopause. But there are other ways of doing this. There's other pathways. We have women's health nurses who are dealing with women day in, day out. They're giving them smears. They're giving them postnatals. Talk to them about the menopause. Raise their awareness of what is potentially down the line from them. The Osteoporosis Society would advocate taking out HRT prevents osteoporosis. We know that HRT prevents heart disease. There are doctors who've had to leave the NHS and move into the private arena in order to be able to work in the menopause. That excludes them from women like me, who up until I became an MP was a dinner lady and a barmaid. I wouldn't have known the menopause if it smacked me in the face. I've talked to all my friends about different illnesses that they've had. Not one of them have ever said they're menopausal. They've had depression, they've had anxiety, they've had, you know, aching knees and aching wrists and aching thumbs. They've been lethargic, they've lost interest in their marriage, they've lost interest in life. But not one of them have ever been menopausal, because they didn't know, and we would never in 1,000 years have thought to go to a private doctor. We couldn't have afforded to go to a private doctor. And we've got to stop this postcode of those who can afford to be treated, being treated through the private medical system. And all women, every woman in this country deserves to be able to get the right treatment, the right prognosis, and the right medication. And until we're at that stage, I and people like me who have become slightly obsessed and disappointed and appalled at the way that women have been treated in this world, I'll just keep on banging that drum. And there's loads more I could say, but I'll leave it at that, and I'm happy to answer any questions. But you know, if you own a business, if you work in a company, if you're in a union, which presumably you all are, you know, wherever you are, whatever role you have in life, become a menopause warrior. Make sure the environment around you is conducive to women on the menopause. Make sure you talk to women about the menopause. Make sure you encourage women to talk to each other, because that's how women are learning about the menopause, from each other, not from the medical profession, from each other. And we've got to stop thinking that somebody else knows better, because nobody knows a woman's body like a woman. And whether the GP thinks she's menopausal or not, if a woman feels that she can and she's medically able to take HRT, leave her try it. If it doesn't work, fair enough. But don't deny a woman her hormones simply because you don't believe she's menopausal, or simply because you believe a myth that was 1,000 years old. we've got to move on. We can't allow this to happen anymore, and I won't let it happen. So I am shutting up now.
No, listen, Carolyn, that was a very impassioned speech, and thank you so much for that. I can see that there have been a couple of questions, but before I do, I mean, I echo what you're saying, and one of the things I want this to start is conversations in many employers about what they are doing, how they are supporting people in the workplace. So you know, hopefully we're going some way to doing that with these employers today. And I would like, if I may as well, to point people to an organisation called HenPick, specifically regarding the symptoms you talked about, because one thing that I saw, which I thought might be of interest to some of the attendees here, is a checklist of symptoms which you can take then to your GP to start that conversation with. So if anyone is interested in that, that's HenPicked. You can just Google that and find out more from that. So Caroline, was there any questions that came through from the attendees, please?
There's a couple. So the first one was, do you think the Davina McCall effect has helped women and doctors support better and talk about it more and I guess support each other more?
Yeah, I think I work closely with Davina, and we are part of something now which is called the Menopause Mandate, which is myself and Davina and Marielle Frostrup and Penny Lancaster and all these big celebrity names who are women who are prepared to talk about their own experience, to throw the light on what it's really like to be a menopausal woman. We saw a rise in the awareness of what menopause really was in the run-up to Davina's first documentary, and then there was a huge hike in the number of women who actually went to their GPs with the information as they come out on that documentary. And then that sort of coincided with my private members bill and all the work that we started doing around that. And then there was another hike in the number of women who were going for HRT. And after Davina's last documentary I saw it early, so I'm not quite sure when it came out on TV. There's been another hike, but you know that will keep on growing. The demand for HRT will keep on growing. The more empowered women are to make decisions about their own body, and the more doctors realise that women do know their own bodies, and the more that we get other pathways, which may include women's health nurses and GP practitioners, because you don't need, if you've got that system set up, you don't even need to see a GP, because they can prescribe as long as they're able to prescribe and they have the adequate training, and that may be the British Menopause Society training, or you know, ideas I'm talking to the government about through the task force is a separate kind of training which would allow those who have the qualifications to attend the training and become prescribers, that they would understand, you know, the pressure it would take off the GPs would be phenomenal. I'll give you an example. There's a GP practice in Weston-super-Mare who had a huge amount of women coming with different symptoms, and it was raising awareness amongst the doctors that despite the fact they were diagnosing one condition and prescribing medication for that condition, the women were coming back within, I don't know, 6 to 7 weeks and saying, well, I don't feel any better, but on top of that, I've also got this. And that raised them to thinking, you know, what is wrong here? And it was the women's health nurse in that surgery who said, well, I know what's wrong with them. They're menopausal. And they made the decision to give her the British menopause training. She now has her own caseload. The only time the doctor sees these women now is if this nurse decides that it's not menopause, and she said that's very, very rare. She does all the smears, she does all the coils, she does all the menopause stuff. The health ratings within that practice has gone through the roof. Another solution would be something that's called the QOFs, which is the quality of pot, or there's a posh name for it. Basically what it means is there are certain conditions which doctors are incentivized to diagnose, like heart disease and, you know, some cancers, like with the smear. So you may be encouraged to have a smear because they're trying to guesstimate what the levels of cervical cancer would be going on, and a lot of the stuff is around heart disease. And so a simple solution to this would be if you incentivize GPs to identify menopause, maybe that would encourage them to be more proactive in diagnosing. And one of the things that I've discussed this week in Parliament was the fact that mental health So there's an incentivization to actually deal with mental health. But how many women are on antidepressants and they haven't actually got depression? They've got the anxiety associated with menopause. But if that GP is not differentiated between one another, it looks as if mental health is and it is a big issue. And I'm not decrying that at all. What I'm saying is, let's be realistic and realise that not all those. I was 12 years antidepressants to find out I'm not depressed. I'm menopausal. You know, we've got to stop making rash decisions about what we think is right and stop women actually making those decisions. So yes, I love Davina. I think Davina's done a fantastic job, but there's a lot more to come, believe you me.
Thank you. One person's already asked, are you able to explain a little bit more about what you're doing in Parliament around this? In particular, sort of.
Yeah, I mean, there's so many avenues that we need to. I mean, you can't chip away at one area of the menopause. You've got to change the whole environment. So, I mean, what we're doing in Parliament is, and I co-chair the government's task force on this, and in our pre-meeting this week, I sort of set my vision, if you like, that I would like every geographical area to have either a GP or a nurse or a pharmacist who is adequately trained and really understands the menopause and actually prescribes and diagnoses within that geographical area. So it's not a postcode lottery, but whether if your doctor understands it, you got a good service. If your doctor doesn't, you get a bad service. There's not having to worry about paying to go private, or in some cases paying something like £80 to do an online pharmacist to tell you you're menopausal and to give you one bottle of a HRT gel, which would actually cost you £9 if you were living in England. It would be free in Wales. No, that's got to stop. That's really got to stop. HRT is not a luxury. HRT for some women is essential, and people got to stop thinking of it as such. So that's one area that I want to look at, of making sure that there's no postcode lottery, that every geographical area is a qualified person to identify and prescribe. The other issue is around, there is no area of social policy where the menopause has not had an effect. I've touched on this around things like, and this is just a basic example, but the criminal justice system. Some women experience brain fog. I go through, or have gone through, all my kids' names when I want to speak to one of them. I go through a whole list. In the office, I'll say the names of every person I've ever known in my life, and I'll still get the person I'm trying to talk to wrong. But anyway, I mean, it's that kind of thing. So you imagine a situation where you're out shopping and you were putting stuff in a trolley, and you put something in a different place in the trolley, and you walk through that till and you walk through that security. You've not intentionally shoplifted, but once you're out the other side and that's not paid for, technically you've committed a crime. How many women have ended up in the custodial system for committing a crime because they were menopausal and the brain fog had affected them? How many women are leaving the workplace because they can't cope with working anymore, or reducing the hours, and that if they're on low income, they've ended up as being dependent on the Department of Work and Pensions and that area. Domestic violence. If you're menopausal and you're anxious, and you can be a little bit, you can have mood swings or whatever, you may be finding yourself in a situation that you and your partner are not getting on. Domestic violence. Every single Whitehall department, there'll be a reason I can give them where they need to look at menopause and they need to do something. So that's where we are at the moment. I am enforcing my will, as I do, on every government department, and making suggestions as to what they could do more to help women who are menopausal. And that is what the mandate is all about. I chair the APPG, where we do all the legwork, if you like. The APPG is getting in people to give the evidence. We're producing the reports. We give the reports to the government, and the mandate, we use that platform of celebrities to get the message out there. And we will keep on going until menopause is something which is included in every aspect of political and social life.
Brilliant. Thank you. Really great answer. We've got it's almost a two-part question that's coming from a couple of people. One, when will HRT be free? And also, is there anything being done or championed in Parliament about GPs having more funding and more time to spend with patients, because they're not always quick things to be able to talk through symptoms that you might have to be able to diagnose in detail, and it's the sort of need for more time to be able to talk to them.
Yeah, I think I've touched on that in the sense that it hasn't got to be a GP. If you've got someone who's qualified to prescribe, and I honestly believe that women's health nurses and pharmacists are fast becoming the best people to deal with this, because they probably have more contact, they have more time, they're able to set up clinics. For example, the doctor doesn't run the insulin clinic. I'm not diabetic, but I know that there are very many places where you have diabetics clinics. They are run by a nurse rather than a doctor. So menopause can be one of those issues which can be run as a clinic, or by someone other than a GP. As to the issue with HRT, the cost of HRT, this really infuriates me. So if you live in England, Scotland, so if you live in Wales, Ireland or Scotland, you don't pay for it. So hence why I did the private members bill last year to make HRT free for women in England. And initially the government's response was that they didn't want to pay for everybody's prescriptions, so there would be free prescriptions for all. So I'm like, imagine living in a country where you don't pay for prescriptions. Oh, how awful. Coming from Wales, that's my world, but there we are. Anyway, so I then discovered that women were not just paying £9 or whatever it is, because I don't pay for them. I'm not sure, £9.45 or something like that, because HRT is more than one hormone. So you get charged per hormone. So I first of all said that I wanted women then to only pay one cost, so it would only be £9 something, and that they'd only pay for that once a year. So they said yes originally, and then they came back and said that they couldn't do it for £9 instead of £18, because the £9 was built into the GP contract. So they'd have to renegotiate with the GPs to allow it to be £9 or £18. They've since come back and said that they're unable to do that because through the negotiations that hasn't happened. So you will have to pay £18. Then you were meant to pay from early in this year. It was meant to come in that you only paid once a year, regardless of the number of times you went to renew your prescription. So time was going on, and I was telling women, oh, it's soon, because I was told it was soon. Early in the new year, I was told. And then I was in a Women and Equalities meeting a couple of weeks ago, and the minister said, oh, it's not going to happen until April 23, because we can't negotiate these things, and the computer system that we need to actually deliver these prescriptions is going to take 2 years to develop. But we've told them we need it done in a year, and almost as if I should give them a pat on the head for being good people for doing this. And I was incensed by this, because I can remember when we actually had prescriptions that were written by hand. Obviously that's a concept the government doesn't understand. So they were trying to say that we can't have you can't have this annual prescription. First of all, they said they couldn't do it this year because the demand had gone so much that doctors were giving women a year's supply of HRT. I've never met anyone who's been given 12 months supply of HRT, but NICE guidelines say that you can. Well, they don't actually say that, but that's what the minister first said. Then she said that they were going to reduce the amount of HRT doctors could prescribe to 3 months. Well, if you can get 3 months, congratulations, because I know very few people who can get 3 months at a time. Anyway, they come up with all these reasons why, and basically they say it's a computer system. And so I've given them a few ideas, like, you can have a pen and a piece of paper, and you can write on it 2 months prescription, tick, come back in 2 months, you can have another 2 months free. I think they're working on that idea, but I won't give up until women this year have access to annual prescription, whether it's a printed computer or a piece of paper. And when I said that in the meeting this week, I was met with gasp by the civil servant who said, pen and paper. Yeah, you can use pen and paper, and that's what we have to do. So I accept that it may take a year to develop a computer program, but I don't accept that we can't have anything in the interim. So my task at the moment is making sure that happens ASAP, because currently one of the reasons that women weren't going for HRT, if they could get it prescribed, is because they couldn't afford it. And it might only be £18, but if you were struggling to put food on the table and shoes on your kids' feet, you're not going to prioritise your own health and pay £18 for a prescription. That's the truth.
Thank you. And the only other thing that's been sort of going on in the chat is discussion around, and I don't know whether this is for you or for any of the others, but about whether a plant-based diet can be good for people who are going through symptoms. And I know that
last one to ask about diets is me. I'm the weakest woman in the world when it comes to diet. So I mean, but you know, I don't know that, but I just know that, you know, HRT is all I know. If you can't take it, there will be alternatives, but
Thank you, Carolyn. That was great, really impassioned talk there, and I think given people a lot of food for thought. So we were due to take just a few minutes to break now before we come back with Claire and Joanne to go. So can we take 5 minutes and come back at 10 past, and then Claire, you ready to go? Is that okay, everyone? Brilliant. Thank you very much. Okay. Thank you. Welcome back, everyone. Hopefully, everyone's supposed to grab a drink or whatever. Thank you for joining us. Now, we've obviously heard from Dr. Shabari Hosur about medical point of view, and from Carolyn about, I guess, more political point of view. Now, I think we're going to go a little bit more into the business side of things. Okay, so what actually we're looking at in terms of helping, supporting employees, etc. And delighted to introduce Clare-Louise Knox, business psychologist and founder of SeeHerThrive. And I'll let you explain what all that is, Claire. So just over to you.
Thank you. Hi, everyone. It's wonderful to be here today. Thank you so much for the kind invitation. And oh my God, I've never felt so seen. I got quite emotional when Carolyn was talking. As a perimenopausal 36-year-old, I just want to give a big yes, thank you to that. So just bear with me for one moment while I share my screen with you, and we will get rocking and rolling. Hopefully you can all see that. Nick, can you give me a yes? I can't see.
Yes, we can see that, yeah.
Okay, so I think it's important before we dive into this to just get a sense of my angle, my perspective, the lens through which I see this, so you know who this person is speaking to you today. So I'm a business psychologist, and what that means is I'm a scientist, and everything I do is grounded in research and is evidence-based. So no gimmicks, no things that are kind of plucked out of the sky. Everything we do at the organisation is evidence-based. And the reason I set up SeeHerThrive, and again, I think it's important for you to know this, is because I was a secondary school teacher previously, and I live with a condition called premenstrual dysphoric disorder, PMDD as it's abbreviated. And you may or may not have heard of it. We don't have time to delve into that today, but it's a menstrual related mood disorder. And as a secondary school teacher, I was being swamped with symptoms every month. It's actually classed as a mental health condition, and so every month I would find it incredibly difficult to do my job and to just survive at work, let alone thrive. And over time it became really exhausting. It was really having an impact on my mental health, and I kept it to myself, completely to myself. I didn't tell colleagues, I didn't share it with my line manager, and I started to look at what support was available for PMDD in the workplace and found absolutely nothing. There was no kind of workplace awareness, information, resources, support, and so I kind of made it my life's mission, if you like, to be the person to change that and to do something about it, because it affects 1 in 20 women. And so there's a huge number of women in the population who are living and working with this condition. And it's very, very similar to menopause. We face the same healthcare barriers and challenges. There's a huge lack of awareness. We often experience medical gaslighting, and I could go on. So I retrained and set up SeeHerThrive. And what we now do is work with organisations. We've been going since 2018, worked with hundreds of organisations across many different industries to improve workplace awareness and support for female related health conditions. The things that get missed off the radar, the things that we don't talk about, they're often stigmatized, shrouded in secrecy. And so we aim to break the silence and make sure that women, excuse me, women have got the support they need to thrive at work. And in terms of menopause, so I mentioned I'm actually on that roller coaster myself, and it's an absolute shit show. I just wanted to say that. So if you're on that roller coaster, I feel you 100%. Today, I've had a night of insomnia, so I'm feeling not too fresh. Yeah, so forgive me if I'm not as articulate as perhaps I normally am. But yeah, I was up at the crack of dawn this morning after a very poor night's sleep. But it's at work where women are finding it most difficult to manage their symptoms. And I think we can understand why when we think about the pressures of work, the stresses that are associated with work, but also the expectation or the challenge, I guess, of maintaining a professional persona and identity. And there's a lot of crossover between personal and professional when it comes to menopause, and that can be a really difficult thing to navigate. As Carolyn mentioned, sadly, there are people who perceive menopausal women as being incompetent. So what I want to say straight off the bat is that any adjustments and any support that somebody needs in the workplace because of their menopause symptoms, it does not mean they are incapable. This is nothing about capability at all. People can still do their job. It just means that they might have reduced capacity and they may need some support or different ways of working. So that's a message to spread far and wide. It is not a question of capability, but often it's about capacity. And let's just look at how women are affected before we talk about, I'll give you a few case studies of organisations we've worked with and what we've kind of done. But there was some fantastic research from Dr. Louise Newson last year, which had some really eye-watering findings. And I'm sure to many of you this won't be a surprise, but what this screamed of was a complete lack of awareness, knowledge, understanding, and support in the workplace. And women were saying that 99% of respondents in this particular survey were saying that menopause symptoms had had a negative impact on their careers. And we wonder why we've got a workplace gender gap. We talk about the gender pay gap. We talk about things like the childcare penalty and the motherhood penalty, but we don't bring menopause and menstrual related conditions into that conversation. And this is a huge piece of that jigsaw. What we see is that a lot of women, because of their symptoms and how debilitating they are forced to take time off work. And again, I'm using that word deliberately, forced to take time off work. Nobody wants to take time off work. Nobody wants to ring in sick. If you've ever had to call in sick, you know how awful it is when you have to do that. Those feelings of guilt and shame and embarrassment. So when women have to take time off, it's not a choice they are making. It's often a last resort. And why do they take time off? Well, some of the reasons cited were reduced efficiency, poor quality of work, and poor concentration. And we've talked about the cognitive impairment of menopause, and this brain fog is a real thing. It really does exist. We've seen it on brain scans, the impact to the centres of the brain associated with executive functioning skills. So things like organisation, decision making, being able to articulate thoughts and ideas, being able to present, being able to read and take in information. These things can be incredibly difficult if you are perimenopausal and you're being affected by brain fog. Also, speaking from experience, I'm very, very good friends with brain fog, and I know how hard it is, and it's really frustrating. There's nothing worse. We've seen some interesting patterns in terms of things that are going on. Carolyn mentioned we've got women leaving the workforce, and that's absolutely right. What we see is that women who are off on long-term sickness absence, so that's what, 8 weeks or more, took early retirement. 50% of them took early retirement. That's huge. You know, we've already got a real struggle with recruiting and retaining female talent. And then we've got our arguably most talented, most skilled women leaving the workforce because they don't feel supported. On a similar thread, we've got women who, because of the impact this has on confidence, and you know, we've explored what this does to our self-esteem in terms of thinking we're going mad, perhaps we can't do things as well as we used to, and that negative self-talk, which, believe me, can chip away and eat away at even, you know, you're left with an ounce of confidence. It's really, really difficult to live with. And what that means is many women aren't putting themselves up forward for promotion, or they're being overlooked for promotion, perhaps because of some performance management issues that are going on. And I think one of the most shocking findings in 2022 was that 60% of people said their workplace offered no menopause support. 50% of the workforce and no menopause support. So just to tap into some of the most reported difficulties, and I've already mentioned some, so I won't labour this, but the brain fog, the cognitive impairment is particularly challenging to deal with. The tiredness, you know, a lot of us experience insomnia. We have night sweats, I have those too, and the tiredness the next day and that hangover feeling can be awful to work through. Feeling low and depressed, and for me, the way that manifests is, and one of the symptoms I had before I was diagnosed as being perimenopausal was I just completely lost interest in everything, in what I was doing, in, you know, things that I normally enjoy, and I just felt meh about everything. And I'm usually a really happy, upbeat, optimistic, positive person, and I just had this really dull, like Eeyore outlook. I wouldn't go as far as to say I was depressed, but I had this permanent feeling of disinterest, which was so hard to grapple with, and reduced confidence. And I think we often forget about the impact of all of these things on confidence. And it's that impact on confidence that can drive a lot of women out and can be a real barrier to progression for lots and lots of women. So what can we do? I said I would share with you some case studies, but first, this is a bit of a roadmap really, based on the evidence, so what we know from occupational psychology research, but also from years of doing this and working with employers. This is what works well for long-term culture change. And what's really, really important is that this needs to be strategic. It's not something that's tactical. You don't do it for a quick win to tick a box. This is about long-term culture change. And actually, starting these menopause conversations paves the way for many other conversations around things like PMDD, PCOS, endometriosis, fertility and infertility, pregnancy loss, perinatal mental health. It really can open up the floor to providing support for so many issues that we as females, unfortunately, because of our anatomy and our biology, we have to go through. And for some of us, it's really tricky and it's really, really difficult. So what does the roadmap look like? Well, first and foremost, it's about raising awareness, educating and upskilling the workforce, and that looks like training. We strongly recommend training for all line managers and HR teams to really give them the vocabulary, the skills, the confidence to navigate disclosures and conversations, through to being able to provide appropriate and effective, reasonable adjustments that take that individual into consideration, because what this can't be is a one-size-fits-all approach. Providing menopause information, again, something we offer is a toolkit which has a lot of self-help resources that people can dip in and out of, but we've already mentioned the fact that we're very, very uneducated when it comes to menopause, and so improving that body literacy, if you like, and giving people access to those psychoeducational resources is a really positive thing you can do. And it just means that people can educate themselves, they can get some self-help resources, and it can also include signposting, which is a big part of this. Updating workplace policies and practices. Now, I just want to pull out one here, and hopefully Carolyn can go away and do something with this, because this is my major bugbear. People with cyclical health conditions are massively disadvantaged with our current ways of managing absence in the workplace. Many HR systems are built on what's called the Bradford factor, which is an algorithm that calculates an absence score. And if you are an employee who, let's say you have 5 days off in a row, this algorithm will spit out a score for you. However, if you're an employee that is off once a month, every month, over a 5-month period, you will end up with a worse absence score than that employee who is off consecutively, because you're seen as more problematic according to this algorithm. And what we're seeing, and this is real, this is really happening in workplaces, is we are contacted by people who are facing disciplinary proceedings and who've been fired because of their sickness absence record. These trigger-based absence management policies which do not take into account cyclical conditions. Yes, I know you're supposed to make adjustments, but not every organisation does that. And so we have got people who are being unfairly dismissed and discriminated against in the workplace. That's really happening. Set up a women's network. I'm going to talk about that in a sec, and holding regular talks and events. The calendar is peppered with women's health awareness days. We've got International Women's Day on the 8th of March. We've got World Menopause Day on the 18th of October. Not to mention Endometriosis Awareness Month, PMDD Awareness Month, Perinatal Mental Health Awareness Week. There are tons of opportunities to jump on. So the goal ultimately is to raise awareness, to educate, to upskill, to break the silence, to create an inclusive culture, and to allow people to talk openly and seek the help and support they need. And so the way we've worked with organisations is it's different with each organisation, depending on what that goal is and what some of the challenges are and some of the opportunities. But I wanted to talk you through MCOR, and MCOR is an organisation I've been working with for a number of years now, and they're really the gold standard. I would say they're doing it really, really well, and it's having a really significant impact on well-being, on culture. So that is, if you want a kind of gold standard, this is what I would say is one way you can look at it. So we kicked things off with a webinar on International Women's Day. I think it might have even been 2020. looking at women's health in the workplace. What is it? Why is it important? Why do we need to talk about it? And then that led to other events, because employees, having been given permission to be open, to speak up, to talk, to share, to engage with this subject, wanted more. And so we then had a webinar called Let's Talk Menopause, which was focused 100% on menopause, looking at what is the menopause and what can you do if you're experiencing symptoms in the workplace. We followed that up with training for line managers and HR, which was a really natural progression and built on the Let's Talk Menopause webinar. We then had a session specifically for male colleagues, because one of the challenges that people come to us with is, well, how do we engage men? How do we make it, okay for men to come along? And I think, based on experience, creating a safe space for male colleagues to come along and be able to talk about things that are important to them is also a positive thing you can do. They then introduced the menopause toolkit, which I mentioned, so have that ongoing resource for people to use and dip into. Then we launched a monthly women's network, which I facilitate every month, and we started off having it as a bit of an open forum where it was, just generally checking in with each other, talking about things that were going on for us. But now it's more of a seminar and discussion format, and we take different topics like imposter syndrome, like HRT, migraine, work-life balance, and we've got a 12-month program, and that has been transformative. And Carolyn mentioned the power of bringing women together and giving women the opportunity to come together. 100% agree with that. So we then did various other things. There was a site visit to do an in-person menopause cafe, which was wonderful. And then the next steps are, we're going to be rolling out broader women's health provision, which is just so exciting, and just, it's going to make such a difference to the women in this organisation, and I can't wait. And this is what one participant she joined the Women's Network and came along to those sessions, and it's still ongoing. We're into our 2nd year now. But she found it really inspiring. I've had people who've said it's given them the confidence to go and speak to their doctor. It's helped them to navigate conversations with their managers. So it really has had a profound impact. And then a male attendee who came along to the menopause training, who got in touch to say went away and had a fantastic conversation with his female colleagues about the menopause, which he would never have done because he wouldn't have had the confidence. So it really does make a difference. Bit of a finance case study for you. I was recently involved in an event with Barclays, which wasn't specifically on menopause. It was actually on premenstrual disorders. But the way they've approached it is slightly different. So they have a range of employee-led diversity and inclusion networks, and they advocate for the inclusion of women's health issues. And it's really employee-led. They organise different talks and different events. And so I was involved in one called That Time of the Month, which was great, and again was aimed at opening up the conversation, raising awareness and signposting people to support. We also talked about how to advocate for yourself in healthcare, because as we've seen, people don't always get the treatment and support they desperately need. And yeah, another different organisation, a marketing company. So they have approached it and incorporated menopause into their invisible health policy, which has a wide range of different conditions included in it. But we kicked that off with a webinar. Again, webinars open to all employees are such a great way to kind of lift the lid on the topic and get people curious and get that engagement going. We then followed that up with 2 manager training sessions, which again was fantastic. We did those in quite small groups, so there was a lot of time for Q&A and discussion. And then we're rolling that out again with their sister brand in Amsterdam. So I'm hopping over to Amsterdam next month, and we're doing the same again. But that is because it had such a positive impact that they want to roll this out globally, which is great. So if there's time, Nick, is there time?
Yeah, we can give you a few more minutes, Claire.
Yeah.
Carry on.
I'll run through this. It's really hard to condense everything into 20 minutes, but I'm really happy to chat with people another time. But some of the challenges we see, I thought this might be helpful to share for anyone who's kind of broaching the subject of women's health in their organisation. So getting buy-in from senior leaders and executive teams, you do have to sell the business case. And there's so much data now around the impact of some of the conditions we've talked about and menopause on individuals, teams and organisations. So it's not that difficult to build a really solid business case as to why it's important. I hate having to do that because to me, it's the right thing to do. You know, if we are focused on diversity and inclusion and employee well-being, it just, you know, it's part of those conversations and it should be there. But sometimes, you know, especially to secure budgets, we need a business case. Policies. So it's great that organisations are introducing things like menopause policies, and they're absolutely well intended. So I'm not, I don't want to dampen that at all. But often they're missing some very important aspects of menopause, and you know, there's diversity and inclusion within menopause. So it's not often I see things like premature ovarian insufficiency, early chemical and surgical menopause included in menopause policies. And they are very different experiences to people going through a natural menopause, very different. And the challenges are very different. And intersectionality, so trans and non-binary experiences of menopause, women of colour, women who have other needs, additional needs, neurodiversity, and all of these things that we need to really, really consider when we're writing policies. Male involvement, which I've talked about, so that's one of the main questions. How do we get the men to come along? One client did a fantastic thing, which was instead of bring your own bottle, BYOB, it was bring your own bloke, and that worked really well for that company. It might not work everywhere. Training, trying to deliver training in-house. Now, menopause is a very specialist subject, and it requires an expert. And the other thing I want to say to that is there has been an explosion of menopause experts and consultants trying to capitalize on this new market, let's say, and this new opportunity. Be very wary of who you engage with and who you work with, because I've heard some absolute horror stories about experts delivering very serious misinformation. If you're concerned about that, then again, I'm more than happy to have a conversation with you and kind of sense check anything. That's absolutely fine. Closely following that, we've also seen the emergence of menopause-friendly accreditation schemes. I completely disregard these. We know they don't work, and actually they can have detrimental effects, because what that does is it sends out a message of, or it can send out a message of, well, we support menopause, but what does that mean for people with other conditions? And where do you stop? Should it need that, or is it a gimmick, and is it a marketing scheme? I will let you make your own mind up as far as that goes, but unfortunately they're often very expensive to take part in, and they're not grounded in evidence, so just be wary of that. The aforementioned company is a big, advocate of these menopause-friendly schemes, so I just wanted to make that very clear as to where I stand on that. On a similar note, tech versus human approach, we've got some really good tech solutions coming out to support employees, but with such a personal human topic, don't lose sight of that human approach and the value that the connection with people can bring. And one thing just to have on your radar, because some of you, this might be under your remit for some of you, private healthcare, this is quite recent, but we're getting women coming to us who they have private healthcare through their employer, but when they try and seek treatment or care for menopause or PMDD or endo, they're being told that that should be dealt with from their GP, and they can't access that private healthcare, which is just another bone of contention, and it drives me mad. But yes, I'm not going to get on a big rant about it. Anyway, that's it. That's been a very, very quick overview. Hopefully it's been helpful. If you want to have a chat at any time about anything that we've talked about today, then please do connect, get in touch. I am very happy to jump on Teams and have a cuppa and a chat. But yes, we're here to support you in any way we can. So thank you very much.
Thank you, Claire. That was really interesting. And I will do, I know you said your self-promotion is not something that you're always very good at, but I will do it for you, because knowing the SeeHerThrive website, and I know that there's been some chat about this, the toolkit that you offer, the policies that you offer, it's all there. So if people want to start that conversation with their employers, or if any of you out there are HR experts and want to have a look at some of the stuff that Claire and her team have been doing, it is on there. I will send out a link to SeeHerThrive afterwards as well, so you can all have a look. What I want to do, because I think a number of what you said actually is going to be underlined by Jo in a minute, from a Zurich point of view. It just some of it I think very much resonated with some of the stuff that Zurich are doing. So rather than going into questions now, I'm going to pass straight over to Jo and then kind of do questions at the end of that. Is that okay? So Jo, I will pass over to, if I can just spotlight you, and I'll pass over to you then.
Fabulous, thank you so much. And I'm going to literally crack on. I think I would probably say Claire talked about brain fog and it being a close friend of hers. I'd say it's probably my best friend at the moment. And it could be for two reasons for me. A, I'm a 44-year-old woman who I believe is going through that perimenopausal stage. And secondly, I had a little bit of an incident with COVID and I'm suffering from long COVID. But it's real and it's there. So I don't apologise for the fact that if any point in time I just stop, it's maybe just because I'm having that brain fog moment. But it's brilliant to be here today, and it's been fantastic to hear a whole array of speakers coming at it from really different perspectives. I guess what I was invited along to talk about is what we're doing at Zurich, why now, and talk a little bit about the process for building that policy and framework, and the process that we went through. So we don't have a huge amount of time, so I'm going to whiz through it, but actually I want to just play you a quick video, because this is something that I think is particularly useful, but I just want to see if I can get that first of all. Nick, can you see the screen?
Just see the PowerPoint. It's not
moment.
yeah, there you go. The sound's not working there, Jo.
Hang on, wait a minute. It's not working. There we go. Technology always throws these issues up for you, doesn't it?
Even though we tried to prepare.
Well, it worked earlier, didn't it, as well? I'm just going to have a little look. I don't know whether it's whether you spotlighted me, because I know we managed to get it working. Let's have a little go. Dismiss. Because it's suggesting that I've got the speaker on. So let's see if it works this time. Any different?
Still can't hear it. Unfortunately, on the share, are you able to see where it says include computer sound?
Ah, here we go. Let's have a little go again. Third time lucky.
Menopause is a natural part of life and affects roughly half of our UK population. That's why we're working to make Zurich more menopause friendly.
Offering support at work not only helps those who experience the menopause, but will also help us to support their families and partners. That's why we're proud to launch our new UK menopause policy.
We want to create an environment of openness to talk about and normalise menopause, help colleagues to remain in work and thrive, as well as attract and retain valuable talent now and in the future.
Our policy will highlight the support and adjustments that can be made to make life that little bit easier, recognising that everybody's journey is different. So whether that's a little flexibility at times when the most debilitating symptoms hit, to small changes that will help you with your work environment.
We're also educating our people leaders to understand the role they play through our leadership awareness sessions and providing helpful toolkits and information.
Let's make it okay to talk about menopause.
Okay. Can you see the slides again? Lovely. So just really setting the scene, I guess. We are a global financial services company in the UK. We have over 4,500 employees. We have been on a bit of a journey over the last couple of years where we have a well-established UK wellbeing strategy, and we do pay, close attention to policy and legal compliance. Given a little bit of background as to where this come from, I'll go into in just a moment, but as an organisation, it's really important for us to demonstrate and to listen to our employees and networks. So we have a group of networks, just as Claire was talking about before. And with this particular programme, we worked collaboratively with our Women's Innovation Network. For us, we aspire to continue to be a great place of work for the widest range of people. So inclusivity is really important. I will talk about women when I talk about the menopause transition, but of course, we do acknowledge that our trans, non-binary and intersex colleagues can also experience menopause transition and some of the symptoms associated with it. And I guess one of the things really that for us has been really useful is stats within our own industry being particularly alarming around women leaving roles and not taking up promotions. So we actually were involved in the Standard Chartered and Financial Services Skills Commission, that's a mouthful, survey last year where over 2,400 men and women were participated. And what we established from that is 1 in 10 women in the financial services sector are going through menopause. And within our sector already, we are facing growth and skills gaps. So it's imperative for us that we have those skills internally. We also know that women over 55, it's rapidly increasing. And actually, we need to be having these conversations because of the drop-off and fall of talent, potentially either not feeling able to go for promotions and or leaving jobs. So there's a few things that have been influence of change. And Nick said, why now? Well, actually, we're a little bit late to the party on this. For Zurich, we started these conversations probably 2019. We ran a Women's Health Week and we were talking and invited people to start talking about menopause. Our Women's Innovation Network and my esteemed colleague who's on the call, Pauline White, she's the chair of that network and has been championing this cause with Zurich for some time. You know, in our networks, we have a pivotal relationship with them because they are there to challenge us as an organisation, to help push the agenda on certain subjects. And Pauline has certainly done that. So, you know, worked well with her on this. I think the landscape's changing externally. So there is legislation, there are, you know, roadmaps, there is government movement, as Carolyn has talked about. There has been some great independent bodies and organisations pushing this, CIPD, ACAS, influencers, they're everywhere, now pushing this agenda, and I think we are still at the very tip of the iceberg. I still feel organisations are very much behind the curtain on this, and really behind the times, when still it's only 1 in 10 employers who have a policy. And another influencer for us is the fact that we have ethical practice within our UK organisation. We listen to people. We've got a great executive committee. We have a fantastic chief people officer who has really driven the agenda. So for us, family stages, life stages, it's all been something that we've been looking at in the last 3 or 4 years. So I guess probably some of the things that maybe if you're listening, these are things that we had pinpointed through things like annual surveys, through our Women's Innovation Network, through anecdotal feedback, to kind of say these are some of the areas that we need to look at. People leadership being one, and the role of leaders in shaping somebody's experience, which can be both positive and negative. The attitude and perception towards menopause, and I'll talk to you a little bit about kind of some of the discussions that we had. For us, it's building a long-term collective responsibility to build that culture of informed understanding and support. Education and awareness is absolutely critical to this. And then making it easier to talk about important conversations around different life stages, and how we kind of make those conversations personal and accepting that everybody's different. So I guess our journey, and anybody that's on this here, you can be a change maker, you can push. It may take some time, but you can do it. I think for us, I've just highlighted some of the key stages that we went through. And I will say, having my own background in policy development and employee relations, anybody can bang out a policy. You can write something pretty quickly and put it out there. But actually, to make a policy really stand the test of time and for it to be effective, you need to engage with your people. People are really important for this. But the first point for us, I guess, going way back, was actually having conversations around senior leadership and sponsorship and commitment. And actually, from a Zurich perspective, this really wasn't difficult. So having to go and, if you like, sell the benefits of having this, we didn't actually have a difficulty, because we'd been talking about it for some time. COVID got in the way for us and put the brakes on a little bit, but also, you know, we had senior execs in our business that had been approached by individuals talking about difficult experiences with menopause transition, and I think it really helped us to if you like, gain that understanding around that table. One of the things that we did do is we looked at best practice and research. Santander, I think, are on the call, definitely a standout organisation in terms of where they have been on this journey. But we wanted to have a look at what other people were doing, and not just in our sector. We identified key stakeholders. So if you're looking at developing a policy, and we call it policy and framework, who are the key stakeholders in your business? For us, it was absolutely clear that we wanted to work with our networks, but also to engage with employees on the ground, rather than us thinking we could write it all from our place. We looked at qualitative and quantitative data. So we used things like surveys that our Women's Innovation Network do. We went out and asked for volunteers. So we went out on our internal workplace and said, this is what we're looking to do. We'd like people to volunteer if you've got a story to share, an experience. And this, I think, was absolutely instrumental in the process. And some of those women are actually on this call today. But we did it in 2 different chunks. So we did employees and we did managers separately. And we encouraged sort of people from all genders to join these sessions. In those sessions, we were able to look at, and I guess validate the concerns from individuals about what's the issue now, what do we need to do better, what do we need to do to build a policy that does work, that actually tackles the issues. How do we make it easier to talk about this? We went out and asked male managers to sort of come forward and talk to us about their experiences. Why do you not have that conversation? If you do have that conversation, what's the barrier to doing it? How do you do that in the best way? And I guess it was really insightful. We also had menopause cafe events, and we've actually got another one coming up in a couple of weeks' time. So we made a commitment here, which is to invite people along that can talk to other people. I always say people in the same boat. We're not in the same boat. We've got the same journey potentially, but actually what it looks like for us is very different. Allowing people to come together, feel empowered and open to talk about their own experiences. We shared where we were at with our sort of development of the policy. We tested ideas with them. We did breakout sessions, and then, you know, we committed to and do commit to having them on a regular basis now, to allow that community of people that have built to come together to have those conversations. And I think that they have been probably one of the most successful things that we've done. Talking amongst yourselves. Carolyn, I think you raised this earlier. That's what people do. That's what colleagues, women do, and learn from each other. And it's a great sense of support, and we still see that now. So we also engaged with volunteers to review and provide feedback. So that was lots of different areas to look and test what we were doing for this to be successful. And let me say, this took several months to get through this process. We were not in it to do something really quickly and just get it out there. We wanted to be considered, take our time and really think about an employee-led policy. We went through external experts and sources. So for us, Stonewall, to make sure that we were inclusive in our language. And I will say that, you know, that is something that I think is really, really important when you're considering a menopause policy. In terms of, you know, it can be a bit of a challenge. What do we say? How do we say it? You know, are we marginalising? Are we, you know, how do we kind of approach the whole inclusive language piece? We worked with community. Of course, we've had a really long, strong relationship there in terms of building policies and how they work. As part of our policy, we also looked at people leaders. So we asked them, what is it that you want? What would help you? So we pulled together an internal people leader toolkit and resources. We looked at storytelling series to bring issues to life. Again, this came up as a key thing in the research. People being able to tell their story, that means that actually we're saying menopause isn't just a middle-aged woman going through a hot flush. It is a 29-year-old who's forced into early menopause as a result of endometriosis. It's a male manager whose wife left her job because she felt that she didn't get the support she needed and the stress it caused him in his work. It is somebody that's got a long-term health condition that is managing menopause alongside it. It's a manager and a leader, a manager and a colleague, sorry, that are there talking about it, bringing issues to life to show it's not one size fits all and it impacts everybody differently. And we have our central wellbeing hub. There is so much stuff out externally in terms of information, you know, that's just there and it's accessible to us all. If you just look, you can find so much wealth of information that you can signpost people to. Signposting is really important for when people are looking for information. So we looked at various commitments. I'm not going to go through everything. This is just some high level stuff that we did in terms of practical support. Our policy is, extremely thorough on this, but things that we wanted to make sure we committed to: ongoing menopause training for managers and colleagues. Hempicked delivered a fantastic training session for our employees last September. We have a great relationship with them. They have a really great hub that we can signpost people to. And they actually did a very broad session, but we then also targeted our management population with somebody who had really great experience because she was at the peak of her career, left her organisation thinking, you know, things weren't going well for her, had early onset dementia, and actually it was menopause. So she very much helps us to understand from an organisation and management perspective. But we've also, in terms of some of the practical stuff, flexibility around hours when symptoms peak or prove challenging. And I think it's also us acknowledging that actually menopausal symptoms aren't all physiological. There are many psychological symptoms that people suffer with and that actually can be much more debilitating. So it's about having those conversations, having access to fans in offices and at home, time off for medical appointments. So we have something called flex work, which is where we're empowered to manage our day based on what we have in our diary that day. So not having to feel bad about making time up, doing things in this particular way. It's about managing how you're going to work. The cafe events that I talked about, educational resources. We have a great employee assistance programme and wellbeing third-party support. So they provide telephone support services, online materials, including a toolkit, access to counselling. We've got a virtual GP service. So, you know, it's no, what's the word, brain fog moment again, but, you know, we're all having difficulties, or many, when it comes to getting to see our GPs. All employees at Zurich have got access to an online GP, and they can also speak to somebody who specialises in terms of an interest in menopause. We have support through a private healthcare provider, and we've got an access of a team of mental health first aiders, over 100 in the UK, where people can go for support and also be signposted. So that's some of our commitments that we have, just at very high level. So what's next for us? Like I said, in terms of policy launch, fairly new into this because it was February. We've been talking about it a long time. We want to create and continue to build awareness and education. We have had learning that's been externally facilitated, and we will continue to look at online awareness modules to be rolled out to UK employees later in the year. The events allow us the opportunity to be able to bring speakers in. So we actually have somebody that is due to come virtually to present to us next week from the Black community to talk about Black women or kind of people of colour and how menopause can impact them and the differences, and just to continue to build support. So that's a really great session that's been organised through our networks. We continue the storytelling series. We are looking potentially at whether we want to explore accreditation. So we will pick and choose and look at where we see there is value for us in terms of commitments that we give to the organisation across our different networks, whether it be through disability, through menopause, etc. And we'll continue to build awareness through events and review. So for us, it will be so insightful to see how people feel from beginning in terms of launch to October on World Menopause Day, to see, you know, whether they feel that actually it's working. And as I said before, anybody can bring a policy in. It's easy and quick to be able to develop that, but actually it is about a real cultural shift. So we want to have the best talent. We want women and employees to be able to thrive in their roles, and menopause shouldn't be a blocker towards that. So that's that. And I'm sorry, I know I've probably run just a little bit over.
No, that's absolutely fine. Thank you so much, Jo. I think, yeah, you're conscious of time, that everyone has obviously filled their slots to the brim, and I thank you all for it. I think it's been an incredibly interesting session, and hopefully it's given our attendees the knowledge and empowered even some of them to start those conversations. As I say, I am conscious of time, so I will probably say, you know, let's take any other questions offline, and I can, you know, ask the speakers if they're happy to address some of those, should they have time for that afterwards. So what I'm going to do after this session is send out an email to everyone who's attended with some links to what has been discussed, with the slides that have been shared, if that's agreeable to all the speakers, and some links to things like SeeHerThrive, and the toolkit. I think someone was asking about your toolkit there, Claire. So you know, we'll send all that information out. I'll also send out the colleague support pack, which I was provided from HemPicked, and they have agreed that I'm okay to share that with all of you. So you will see that as well. This session has been recorded, so all technology, hopefully it's all worked, and that should be up on the website shortly. So www.alliance4finance.org. menopause.org. And it just leaves me to say thank you very much for attending, but special thanks goes to Dr. Shabari Hosur, Clare-Louise Knox, Joanne Williams, and of course Carolyn Harris. Thank you so much. It's been incredible. So thank you very much. See you all again soon.
Thank you. Bye-bye. Thanks.
Bye-bye.
Thank you all.